Case Presentation 1. This patient has a left convergent strabismus at rest. There is impaired abduction of the left eye. There is diplopia, which is maximal on left, lateral gaze. Cover testing reveals that the outermost image comes from the left eye. The diagnosis is a left, sixth nerve palsy. Clinical notes. The convergent strabismus of a sixth nerve palsy is due to unopposed action of the medial rectus muscle. The sixth nerve supplies the lateral rectus, leaving an isolated abduction deficit. Diplopia is worst on looking to the affected side. If there is diplopia on left lateral gaze, then this could result from weakness of abduction of the left eye, lateral rectus, or weakness of adduction of the right eye, medial rectus. Cover testing is useful in this situation as the outermost image comes from the affected eye. Case Presentation 2. This patient has ptosis on the right. There is a right divergent strabismus at rest. The right eye movements are impaired, and the eye is fixed in a down and out position. The right pupil is fixed in down and out position. There is diplopia, which is maximal on left superior gaze, angulated diplopia. The diagnosis is a right, third nerve palsy. Clinical notes. The clinical signs in third nerve palsy are ipsilateral to the side of the lesion, as most axons of the muscle supplied are uncrossed from the nucleus to the eye. However, there are two exceptions. Levator palpebrae superioris is supplied from both sides, that is crossed and uncrossed pathways, from central caudal subnucleus. Next is the superior rectus muscle, is supplied from the superior rectus nucleus from the contralateral side. Vesicular, third nerve palsy, results in ipsilateral signs for all affected third nerve muscles, but a nuclear, third nerve palsy. There is additional involvement of the superior rectus and levator palpebrae superioris on the contralateral side. Involvement of the levator palpebrae superioris results in ptosis, often complete, in cases of a nuclear third nerve palsy. Where the nucleus is affected, there may be partial ptosis on the contralateral side. This is because there is bilateral innervation, and the axons for the levator palpebrae come from both sides of the central caudal subnucleus. The horizontal deviation is divergent, due to weakness of the medial rectus. Vertical deviation occurs due to weakness of the superior rectus, inferior oblique, both elevators, and inferior rectus, depressor. The superior oblique is intact, IV nerve, and thus the eye is fixed in a down and out position. In cases of a nuclearal nerve palsy, there may be a weakness of elevation of the contralateral eye. This is because the superior rectus muscle is supplied from the superior rectus subnucleus on the contralateral side. If the pupil is affected, then this suggests involvement of the parasympathetic nerve fibers that originate from the Edinger-Westphal nucleus. This often results from extrinsic compressive lesions, as these autonomic fibers are situated very superficially in the nerve trunk, and, if the pupil is affected, it is termed a surgical third nerve palsy. However, if the pupil is spared, it is termed a medical third nerve palsy. The diplopia is angulated and maximal, looking up and out. Case Presentation 3. The right eye is higher than the left eye in primary gaze. With this, there is impairment of right eye movements, where the adducted eye cannot look down. There is vertical, angulated, diplopia, which is maximal on looking down and away from the affected side. Cover testing reveals that the outermost image comes from the right eye. The diagnosis is a right fourth nerve palsy. Clinical notes. The trochlear nerve supplies the superior oblique muscle, which causes the eye to look in and down. The affected eye appears higher in primary gaze due to weakness of the superior oblique muscle. The diplopia is vertical or oblique. Patients may adopt a characteristic head tilt away from the affected side to reduce the diplopia. Some patients may tilt their head towards the affected side, thus creating a wider separation between the images and allows the patient to ignore one image. This is termed the paradoxical head tilt. Cover testing is useful in this situation, as the outermost image comes from the affected eye. Case presentation 4. This patient has diplopia on looking to the right. The eye movements appear to be grossly intact. The pupils are normal. Cover testing reveals that the outermost image comes from the left eye. This would suggest impairment of the left medial rectus muscle and does not fit with a specific cranial neuropathy. The differential diagnosis would be myopathies, for example Graves' ophthalmopathy, muscular dystrophies, for example oculopharyngeal dystrophy, myasthenia gravis. Clinical notes. The case, where the oculomotor deficit and ophthalmoplegia does not fit with a specific gaze, cranial nerve, palsy. In such situations, it is important to remember that pathologies at the level of muscle or neuromuscular junction can present this way. In the above case presentation, there is a defect in adduction, and this raises the possibility of internuclear ophthalmoplegia. This would typically be associated with nystagmus in the abducting, opposite eye. Although this can be absent, remember, it is a failure of adduction that characterizes internuclear ophthalmoplegia. A useful way of differentiating internuclear ophthalmoplegia from other causes is to remember that in internuclear ophthalmoplegia, the adduction becomes normal when the contralateral, abducting eye is covered.